A lot of information to go through. I have to start with standard disclaimer that this is current as of right now, but things change frequently, especially in this crazy year and a half or so. I am going to jump right into this because there is kind of a lot of information. Some of these slides I'm going to skip over a little briefly. They're more payment information, but you will get a copy of this. So, all right, so let's just start with payment. And I know we don't have a lot of say in how we get paid, but just so you understand where your what's actually going to be happening here. So the conversion factor has gone up to $84 from about $82.80. So that conversion factor is what the weight is multiplied by to pay you. So that's good. The 2% reduction is still going to apply if you're not meeting the quality reporting requirements. And I've got the changes to those at the end of this. Nothing changes as far as the adjustment for sole community hospitals or cancer hospitals. That's exactly the same. This was actually a change from last year, but they are continuing it this year. So I kind of wanted to throw it in here that the wage index adjustments have been calculated differently for the last 10 years as a result of new delineations from this is how current we are, right? We're building stuff based on the 2010 census results, but this kind of resulted in a little bit of swing for some folks. I mean, the biggest changes would have been to the rural hospitals. And the reason I'm bringing this up again is we still have the cap of 5%. So I would expect that people are still changing this year from last year. So there were 10, just to give you an idea, there's 10 hospitals that increased their wage index more than 10%. 50 hospitals increased between 5 and 10%. 1,230 hospitals actually decreased up to 5%. And there's about 1,500 hospitals that had just a slight decrease of up to 2%, and another 500 that decreased somewhere between 2 and 5. So the outlier payments, which can only make up 1% of the total expenditure of OPPS, so it's not much. So in order to make that happen, CMS has raised the dollar threshold of when a procedure could meet that threshold. So you see it was $5,300 last year. It's now up to $6,175. And just a quick reminder that that is your adjusted cost. So that's after application of your cost to charge ratio. That's a pretty high dollar threshold to get around. They're not changing the way it's calculated, though. If you meet that dollar threshold, you're going to get 50% of the amount by which the cost exceeds 1.75 times the APC payment. But just remember that that is, again, after all of your cost to charge ratio has been applied, not just whatever you're charging, but your cost. All right, because we are still in the COVID-19 public health emergency, and it will go at least through the end of this year. I know there's not much left in this year, and then we'll see at that point. Basically what they did to kind of mitigate some of that, and this was a lot because they heard from commenters, and because the 2020 data was just kind of incomplete, they've actually gone back and they're using older claims data to calculate all of your reimbursement amounts. So it's kind of like 2020 for the most part didn't happen when it comes to resetting all these rates. You can see here there's a couple of examples to that. There were a few device intensive procedures that just weren't performed at all in 2019, and therefore they took the 2020 claims. But this is kind of significant, right? Because it's using the old data, but they felt that that was still better than using 2020 data. Okay, this is kind of a big one, the changes to the coinsurance. And I had to read this a couple times because I had thought that the coinsurance was already nil for these screening sigmoidoscopies and colonoscopies, but it wasn't the coinsurance, it was the it wasn't applicable to the deductible. Now we're going to phase out the coinsurance on these when these services become diagnostic services. So a patient comes in for a screening colonoscopy, and during the exam, you see a polyp that needs removal. So you need to code that removal of polyp. You need to put modifier PT on it to let Medicare know that that was a screening that needed to be converted. And what that is going to trigger now is a reduction in the coinsurance. And I guess I shouldn't say now because the coinsurance is going to stay the same for 2022, but you can see it's going to phase out and it will be totally gone by 2030 and beyond. So that's actually kind of nice for everybody. All right, our fun favorite topic that again isn't new, but just so that everybody's aware that that's going to continue, and it's kind of a dead issue at this point. The US Supreme Court has declined to hear this case, and so CMS has prevailed in this, right? And so what this means is when you provide a hospital clinic visit billed to Medicare with G0463, and you do that in your off-campus provider-based clinic, you are, whether you're accepted or not, you're actually going to be reimbursed under the physician fee schedule rate for that. And you can see I put that down there, that's basically, this is not wage adjusted, this is national, but so basically you get $48.54 for those visits when they're provided in your provider-based clinics. Okay. If those visits are billed still inside your hospital, you're going to get paid, continue to get paid under the OPPS rate. All right, and that is that for actual payment kinds of things. Next, we're going to go into the comprehensive APCs, and I'm going to go over this pretty quick. I just kind of do this every year because I continue to get questions on what I mean when I'm talking about comprehensive APC numbers. All right, so just a quick refresher that when I say this, I'm talking about the J1 procedures. There are 69 of them. And what that means is basically if you have one of these J1 procedures on your claim, essentially all of your adjunctive services to support the delivery are no longer going to be separately paid. It's all going to be bundled into that J1. So there are some exceptions. Here are the exceptions that are actually excluded, and these are by separate law. So by law, they have to pay separately for mammography and ambulance and brachy, pass-through, self-administered, these kinds of things, certain vaccines, and the COVID-19 treatments also have to be paid separately. If you have more than one J1 procedure submitted on the same claim, it could qualify for a complexity adjustment. Doesn't mean that it will, but it could. CMS decides, of course, which of those will actually qualify. But just to give you an example there, that if you do debridement of bone and a bone biopsy, it will actually bump it from APC 5072 to APC 5073. And basically pay you about $1,000 more. So that can happen, doesn't always, but it could. The other type of comprehensive APC that we have are the J2s, and those are real specific situations. They're either observation, outpatient services provided when a patient dies before they can be admitted or transferred, and services assigned to new technology. Okay. we don't have any changes to this. Like I said, I just kind of like to go over that. This is the fairly new change to last year that's going to continue. So if you provide any of those approved COVID-19 treatments, you will actually be paid separately for those, with the caveat that it has to be authorized to treat COVID-19 and it has to be authorized in the outpatient setting. If it's one of those that's only allowed to be provided in the inpatient setting, you're not going to get paid for that in any circumstance if you provide that on an outpatient basis. All right, we're going to go over this pretty quickly. Again, it's sort of just payment things to kind of let you know. I tried to just pull out the fairly significant changes out of this, because a lot of this final rule is them going over what they're moving to a different APC or what they've been persuaded to increase the payment on. So I don't necessarily need to read this to you. You can go back through and see, oh yeah, my facility does the MR analysis of tissue composition. And so now we're going to get paid $950 instead of $230. So some of these were significant enough that I wanted to call them out. I mean, you can see the scalp cooling cap measurement of it has gone from $34 to $1,800. Pretty significant there if you provide that service. All right, we have some fairly new technology stuff. Again, just wanted to call this out. This one was actually proposed to be paid at $143. The CMS was actually persuaded by the comments that they got that this wouldn't be accurate reimbursement for this service. And so it's going to be reimbursed at more than double what the original proposal was for. So good news on that. And it really does sometimes, I'm not going to say all the time, but sometimes it really does help to comment on things. Histotripsy is another one. Look at what happened to this. The proposed reimbursement was for $800 and it's instead going to be $12,500. It's a category 3 code. I wouldn't expect that a lot of you are doing that, but that is pretty good news if you are one of those facilities doing that. Minimally invasive glaucoma surgery, as would be coded with one of these codes, has actually not super significantly changed, but the reimbursement did change, and you can see those there. Okay, ophthalmic insert into Canaliculus, there's our code, and that went up from $61 to $325. The status indicator is going to stay a Q1, which means it will be packaged if it's reported with others procedures on the claim. CMS is going to reevaluate that one in the future, though, because according to most commenters, this wouldn't be performed alone. It's going to normally be done with other surgeries. We have bone substitute injection. This would be the AccuFill device from Zimmer Biomet. That pretty significantly went up. The proposed reimbursement was $211. It's going to actually be reimbursed at $2,900. It's kind of a nice one there too. It's nice when they do listen to some of what they're hearing in the comments. All right, our next procedure is lithotripsy with vacuum aspiration out of the kidney, ureter, bladder, urethra. The reimbursement for that is actually going up from $4,400 to $8,400. CMS was persuaded that that wasn't the appropriate reimbursement for that. EGD with pseudocyst drainage is another one that's going up fairly significantly. So if you do that drainage of pseudocyst with or without a stent, you can actually be reimbursed quite a bit better for that one next year. External ECG recording. That actually, it's significant for what it was, right? It's not going to pay for too much, but if you do a lot of these, the reimbursement you can see almost tripled there and almost doubled there. Sacrospinous Colpopexy was reassigned. You can see that that was a nice little, not quite a doubling there. But if you do the sacrospinous minimally invasive, that was actually, they were persuaded to increase the payment on that. This is one of the first years I can remember where it's almost all good news for the reassignments. Intravascular lithotripsy, so that's, you know, where you can actually go into the arteries primarily and break up with the lithotripsy catheter, break up any plaque or, you know, hardened material that's in there and then go and essentially suck it out. It's kind of a cool procedure. That went way up. So if you do any of those sorts of procedures, that reimbursement has become quite a bit better, which allows for the device. You can actually cover the cost of your device. Isn't that wonderful? All right, the medical physics dose. So this is where typically a hospital employed radiologist does the calculation for radiation exposure. The money for that is going up quite significantly as well. And because that is usually a hospital employed physician, generally the hospitals are billing that one. The MiVu mucosal integrity testing, which is currently a C code, has been reassigned. This is really good news because this year doing this, it's actually a bundled service, so you don't get separate reimbursement for this. Next year, you're actually going to get an additional $3,100 for that procedure. And the pathogen test for platelets was not quite a doubling, but if you do any of those pathogen tests, because they're trying to capture now the culture-based tests that are more expensive, they've increased the payment on those. Wow, we have a lot of this stuff to go over, don't we? All right, the therapeutic ultrafiltration, which is basically performed for heart failure patients that aren't responding to diuretics or other types of medical management, that has been assigned to an APC, and it the proposed rule wouldn't have allowed this to be a covered service. It would have been, I think, a status indicator E and excluded. They've changed their minds and it's now going to be a status indicator S, and there will be separate reimbursement for that. So don't confuse that procedure with dialysis. It's not quite the same thing. This is actually for the Aquedex device to treat patients with, as I said, the heart failure, usually acute, but. All right, and last but not least, we have the resume procedure. So the destruction of prostate tissue by water vapor, really cool. That's been reassigned, and the payment on that has not quite doubled, but it's gone up definitely significantly. So if you do that, some winners there on what we, on things that CMS reevaluated. All right, let's talk about devices. We have a lot of devices that actually have pass-through status. So just to remind you, when I say pass-through status, that means that you will receive additional reimbursement when these devices are used on procedures. The reimbursement that you get is subject to your cost to charge ratio and dependent upon the cost that you paid. But you do get, for 2022, using any of these devices, you will actually get additional reimbursement for those things. Okay. Most of these are not new. In fact, none of these are new. A lot of them got extended because of the pandemic and the thought that it was probably not fair to discontinue payment on these devices within their normal time frame because everybody got so messed up with the pandemic. All right, we do have 2 new devices that were approved for pass-through status for January 1st. So in addition to the 11 on the last page, we have these 2 new ones. The ReCell system, which processes autologous donor tissue for application to an acute thermal burn wound. And the Angel Med Guardian, which it monitors a patient's electrical activity in their heart to basically monitor for changes that could be indicative of, a heart attack, basically, or unstable angina. It's really kind of amazing there too. It's amazing to me what they can do every time. Okay, so those will continue for at least 2 years, up to 3 years, depending on what this pandemic does, but that's the current rule. This again is not new, but I get a lot of questions on this still. CMS hasn't produced a list of specific device to procedure or procedure to device edits since 2015. So any device, what they do publish is a list of procedures they consider device intensive and another list of devices that they consider to meet that criteria, and all you have to have is one. It doesn't have to make any sense. So if you're inserting a pacemaker, you could bill a guide wire with that and nothing else, and you're going to pass the edit. Doesn't mean it's right, but you will pass that edit. So despite repeated requests for CMS to reinstate this, kind of cracks me up. They refuse to reinstate this because they expect that hospitals can correctly code all of their procedures and there shouldn't be any problem. And I'm thinking, well, wait a minute, why do we have any of the other edits if we're going to trust that hospitals can perfectly code everything they do? But neither here nor there. Just if you would like to know what are considered best practice devices for your procedures, or you just want to get the full list of device intensive procedures. If you're a VitalWare client, that's all in knowledge. If you're not, it's in addendum P to the final rule. All right, let's talk drugs. There's not a lot to talk about drugs this year. They are doing some funky math, and 6 drugs that would have expired this year on the pass-through status and wouldn't have gotten separate payment this year. They're actually extending that a little bit, again, because of the COVID-19 public health emergency. So there's 6 drugs that will continue to have a status indicator of G and will continue to receive pass-through payment regardless of whether or not they meet CMS's cost bands. Okay, nothing has really changed here. They're still updating this payment on a quarterly basis. If you want to see all those, again, if you're a Knowledge client, all of that is available in Knowledge by looking for the status indicator G codes. If you're not, you want to look for tables 38 and 39 in the final rule. I wasn't going to list them all out. There's a lot of them. Right. As far as the packaging threshold, that is not changing for 2022. Drugs that have a mean unit cost of more than $130 will receive separate payment, and drugs that fall below that are going to be packaged into other procedures. Luckily, they didn't up that rate. That started at $50 way back when, and it slowly crept up to now be $130. Quick reminder that they make those packaging determinations once a year. So they get new cost information throughout the year from the manufacturers, but they don't change the payment indicators except for once a year. All right, the 340B drugs, anything acquired under the 340B program. This isn't a new program. We kind of wish it was, kind of wish it would just go away. The drugs acquired under the 340B program that are assigned modifier JG by applicable facilities are going to be reimbursed at average sales price minus 22.5%, as opposed to average sales price plus 6%. So it's really a net change of basically about 28.5%. That modifier is what triggers the payment reduction. If you are a facility that is not subject to the reduction, like a critical acts children's hospital, Soul Community Hospital, a cancer exempt, you're supposed to be using modifier TB, and that allows CMS to track, but doesn't affect your reimbursement. The reason I'm bringing this one up, although it's not new, is basically we're still kind of holding our breaths and waiting to see what the Supreme Court is going to do on this. They have agreed to hear this case during their current session, and they will be hearing arguments on whether or not CMS exceeded their authority when they did this. So stay tuned. This may not continue, but CMS is holding fast right now for the year 2022. I would expect to hear something probably before the end of next year as to what's going to happen with this, unless the Supreme Court sides with CMS, in which case this is just going to continue. I wanted you to be aware of the skin substitutes that we're actually moving from low cost to high cost. And just a quick refresher there that if the skin substitute is on the low cost list, the procedure would be reported with C5271 to C5278. If it's on the high cost list, the procedure has to be reported with the 15 codes. So that's pretty important to know where those are. Again, if you are a knowledge client, each of these products has in our relationship table, we tell you which one goes with which and when it changed, because these can change quarter to quarter. They don't tend to do a ton of moving around, but it's important to know which, right? Because we were kind of talking about that, like CMS thinks that you guys are 100% perfect in some areas and don't need edits, and others not so much. So this will trigger an edit if you don't get the right procedure code with the right skin substitute. All right, partial hospitalization. I don't know how many people on the phone would have a hospital-based partial hospitalization program. I doubt there are many of you that are actually from a freestanding community mental health center, but I really want to hit this because something weird has been going on with this for a number of years, and it continues, which is every year CMS looks at the data, the costs go down, and they go down pretty significantly. So it's always kind of my plea that if you happen to have a partial hospitalization program, please look at your costs, because it just doesn't make sense to CMS or anybody else that these services are getting cheaper. Essentially, every year you tell CMS, oh, no, you're overpaying me. Please, no, we need to give some of it back. So they are continuing to hold the payment on this steady, because if they didn't at this point, you'd be getting reimbursed maybe half of what, if they just went off of the costs reported, it would basically be half you would be getting. That can't be right. So please, you know anybody, you have these, check your costs for this, because it just can't be possible that costs are being reported accurately for these services. All right, one of my favorite little soapboxes / topics that is pretty hot this year are changes to the inpatient only list. Okay. So let's first talk about that. Last year, if you recall, or not, if you've blocked it out because it's too painful, CMS decided that they were going to start phasing out the inpatient only list. So just as a quick reminder that those are the procedures that have to be performed on an inpatient basis because they've been deemed basically to not be safe on an outpatient basis for the majority of Medicare patients. So last year, CMS said, we're going to phase this out. That will allow doctors to make better decisions. They know who's safe to be done outpatient, who needs inpatient. We're going to go that way. Well, they heard a lot of pushback on that. And I think a lot of people were afraid that then the auditors were going to march in, right, and say, okay, this isn't on the inpatient only list anymore. You should be doing this outpatient. And that was never their intent, right? One of my favorite soapboxes, just because it's not on the inpatient only list does not mean it has to be done outpatient. And they reiterated that 5 or 6 times. But we all like black and white, right? Really nice and easy to say, oh, if it's not here, do this. It's not quite that simple. So anyway, in response to that, they are reversing their decision to phase out the inpatient only list. Basically, they're adding back everything that they took off last year, except for these 5. These 5 are going to remain off of the inpatient only list. So that means it's up to the doctors to say whether or not the patient warrants inpatient care or could be done safely on an outpatient basis. So we've got shoulder and ankle replacement and the corresponding anesthesia codes that would go with those. It doesn't make sense to take one off and leave the other there. And then we also have lumbar posterior inner body fusion is also now can be done on an outpatient basis if appropriate. Okay. If you want the full list of those, again, if you're a Knowledge client, you can go to Knowledge, ask for, query the procedures with the status indicator C and get that full list. Otherwise, it's table 48. All right, I just wanted you to have the list of criteria that they use to remove procedures from the inpatient only list. They're actually codifying this, so this is now the way that this has to be done. So a procedure doesn't have to meet all 5 of these criteria, but they do have to meet at least one, and the more they meet, the greater the chance they get removed from the inpatient only list. So you can see it has to be outpatient departments have to be equipped to provide the services, and it's CMS, so everything is in the context of the Medicare population. The simplest procedure described by the code can be furnished in most outpatient departments. The procedure is related to codes that have already been removed. I don't quite know how the determination is made that the procedure is already being furnished in numerous hospitals on an outpatient basis, or it can safely be furnished in an ASC and it's on the list of ASC services. Any one of those kind of qualify the procedure to be removed from the inpatient only list. And of course, you can always write in and comment to CMS if you have a code or codes that you feel should be removed or added for that matter. All right, the 2 midnight rule kind of goes into, it kind of relates to the inpatient only a lot because of what we were talking about there with auditors. So, and CMS hit this again pretty hard. This is going to stay in place, right? So if there is a procedure that is on the inpatient only list, that needs to be billed inpatient. Even if the patient stays for 1 day, that is an inpatient only. It's not subject to review by the RAC for length of stay. It's inpatient, right? They can't say anything about that. Also, procedures that are removed from the inpatient only list are going to be exempt from RAC review for patient status for 2 years. So don't take that as it can still be reviewed to make sure that it met medical necessity, and it can still be reviewed to educate the hospital on other things, but it can't be used for, it can't be reviewed for patient status. So that's an important one. CMS reiterated this again several times. So I'm going to read it verbatim. I think it's super important. It is a misinterpretation of CMS payment policy for providers to create policies or guidelines that establish the outpatient setting as the baseline or default site of service for a procedure based on its removal from the inpatient only list or the elimination of the inpatient only list. So what are they saying there? Just because it's not on the inpatient only list doesn't mean that anybody can tell the doctors that it has to be done on an outpatient basis. It's still up to the doctor to determine the appropriate site of service for the patients. So again, I know we like simple and easy. We like to just go through our QualMed criteria and say, ding, this should be outpatient. CMS also reiterated that the QualMed criteria or interqual criteria, any of that stuff, that's not binding on the decision. It can be used to guide things. If you go through the interqual criteria and it tells you this is likely an outpatient, you can use that to guide and you can have a conversation with the physician, but that's not binding. So keep that in mind. All right, our fun hospital price transparency. I don't think this is going to be news for everyone. This is probably the hottest topic when the proposed rule was released. They are increasing the civil monetary penalties for noncompliance. So if you're a hospital with 30 beds or less, you're going to pay $300 per day. Okay, that's essentially the floor on that. Everybody is going to be charged at least $300 a day. If you're more than 30 beds, you are going to be calculated at $10 per bed per day. So you can see what's going to happen with that. The amount caps at $5,500 per day, and that's per facility. Number of beds is going to be determined based on the most recent cost report. And if you don't have a most recent cost report for whatever reason, CMS is actually going to ask you how many beds, how many licensed beds do you have? So right now the penalty is $300 per day for everybody. This is going up very significantly if you're a larger hospital. So they're serious about this. They want hospitals to comply. The other thing that they did was they admitted it was just a mistake that they didn't exclude in the beginning the state forensic hospitals. So those are public psychiatric hospitals. They only provide treatment for individuals who are in prison, in jail. Obviously, I hope none of us are shopping for services at those hospitals. So they are excluded from the rules. They don't have to provide their transparency data. Okay. It's important to know though that just if you do some treatment for those sort of patients, but your hospital isn't exclusively that, you still have to provide the data. They also reiterated, I guess, what hospitals can't do. So just a reminder that your information has to be accessible to an automated search. There has to be a direct file download. Your link has to be posted on a publicly available website, and you can't use any kind of blocking or CAPTCHA. Okay. They've also said that the information should be available with minimal click-throughs. So basically they don't want it buried, right? You shouldn't go to a hospital's main page and have to click down 8 layers to get to the file. It should be very clearly identified there where you get the pricing information, and you should be able to download a single machine readable file. That's not really new. They kind of just, I guess, clarified how you are not supposed to be blocking or prohibiting any of this. All right, and then this is another section I'm going to go over fairly quickly. This is important stuff though, right? I mean, if you don't comply with the quality reporting information, you've just lost 2% of your payment, and not really for any great reason. So just wanted to make sure everybody knew what we've got here. So they are proposing to remove, and actually it's finalized, but it won't happen until 2023. So measure 2 and 3 are going to disappear because they're basically covering those better with different measures. So you don't have to report these anymore for 2023. 2022, we're actually adding 2 things. So take note of these, right? There is a COVID-19 vaccination coverage among healthcare personnel and a breast cancer screening recall rate. Those are both going to take effect here next year, okay? You can see what's happening here. This one will be required for 2024, voluntary, and I've got on the next slides exactly what these are so that you can dive a little bit deeper if you need them. The other thing that's really important is the OPPS survey, which has been delayed for lots and lots of years. That is actually finally coming in. It's going to be voluntary for 2023, but it will be required for 2024. So the first one that you need to worry about in the immediate future is the COVID-19. So again, for those people that need this information, I've got in here what the denominator is. So basically you pick a self-selected week, and you're looking at the number of hospital personnel who were eligible to work at least 1 day. And then the numerator is the number of those people that actually have received the full vaccination course. That's going to be reported through the CDC's web-based surveillance system. The next one that's coming in is the breast cancer screening recall. They don't want this number to be too high or too low, so they're looking at the number of Medicare patients who got a screening exam. And then the numerator is the number of people who got a diagnostic exam within 45 days of that. And that one's just going to be collected. Nobody has to do anything on that. You don't have a choice. It's collected from your claims data, and it will be out there. Okay, this is the one that's not coming in until 2024. This is kind of what's replacing the 2 that are being removed. Okay. So it's just kind of combining the 2 into 1, basically. This is what's sort of important, is what are you looking for and how do you have to do it, right? Do you have to abstract out of the data, or is it going to automatically be done for you? Okay, this is just a quick so that you've got the measures that are in effect for 2022 that have to be reported on in some way. And we already went over the changes to those. And then I'm going to just briefly talk about the radiation oncology model. We had a webinar on this yesterday. So if you missed that and you're interested in more detail on that, I'm going to refer you back to that. You can go back to our website and actually get more information. But just wanted you to have some high-level basics in case you're not aware of this program and you're in one of the areas that it's going to impact. Okay. All right, it's going to start January 1st. It's not going to apply to providers that are in Maryland, Vermont, or the territories, Guam, American Samoa, that kind of stuff. It's not going to apply to ambulatory surgical centers or critical access, cancer hospitals, or facilities who are participating in the Pennsylvania Rural Health Model. Okay. So if you want to see, you're not exactly sure whether or not you are participating in that or want more details, you can do that there. It's also not going to apply to hospitals who are participating in the Community Health Access and Rural Transformation Model. And if you opt out, you have to opt out if you want to, but if you provide fewer than 20 episodes of radiation therapy, you can opt out due to low volume. So you may want to do that. In fact, you may be too late on that if you want to opt out for this year. Okay, so it applies to certain cancer types. It applies to certain, not exactly certain settings, but there's different payments for that. So they chose which cancers to include because they had to be commonly treated with radiation. They have to have current ICD-10 codes, and CMS didn't want to determine that they'd be inappropriate for inclusion. So liver cancer has been proposed for removal. So here's your cancer types that are included in this new model. And if you're in one of the zip codes that has been selected, unless you're one of those facility types, you don't have a choice, right? You're going to be included in this. Here's the types of therapies that are included. Kind of important to note that they removed brachytherapy from this model, much to everybody's relief, because brachytherapy doesn't fit real well into this model. But here are the therapies that do actually fit into this. And as I just said, if you want more detail than I just gave you there, you can go back to the VitalWare website and actually go take that course, go listen to the replay and get more information on that. Right? That is what I have. Marie, can I turn it over to you? I think I suppressed my little, not sure I can get to the questions as easily.
Yeah, absolutely. We only have a couple questions right now.
Sweet.
Let's see. First one, regarding device to procedure edits, sometimes the implant does not have a HCPCS code, human bone, for example. What do you recommend to use for those?
Well, CMS created, I think it was in 2017, but don't quote me on that. They created a HCPCS code C1889, which is designed to override that edit if the device that you're using doesn't have a HCPCS code. So C1889 is for those devices in order to override that particular edit. There's also a modifier that can only be used on a certain number of procedures. I can't quote those off the top of my head, but I can put it in the FAQ document that we'll send out to give you a little bit more information on that. But there are ways around it.
Great. And next question, is VitalWare going to be sending out a crosswalk of procedure to HCPCS that will resolve the device edit?
No. That is information that if you are a knowledge subscriber, that is all available to you out there with our best practice recommendations and whether or not your procedure is actually considered device intensive. We've gone ahead and done all that work to parse out the I and OCE information where all that's kept, but that has been a lot of work that's proprietary. And so if you're a knowledge user, you will get that. Otherwise, you need to go through the I and OCE edits that are published on a quarterly basis and take a look at that as it changes.
Okay. We don't have any other questions right now, actually.
I like it. So either I put everybody to sleep or
or you did a great job.
Yeah, I'll go with the second one, right?
Yeah.
I like that.
Yeah. Well, I guess if nobody has any other questions, we can wrap this up. So just a reminder, an email will be sent by end of day today with the CEU certificates and a link to the recording and the slide deck. And we will have those couple Q&As posted in a week or so to our website. And if you would like to attend our last webinar for 2021, you can go to our website and register for that. But I think that's all. Let me make sure no other questions came in. There's one comment that makes it difficult to set up and edit in Epic, and we have CDM and knowledge. But not a question. So I think that that's all. Thank you everyone for your time, and thanks Jen for a great presentation.
Perfect. Thank you.
Thank you.
Bye.